Welcome to Dr Joe Unplugged. This podcast contains general information and is not in any way medical advice. Statement of the obvious. All medications can have side effects. I want to reiterate that in this podcast, I'm not providing any medical advice or information, so anybody who's on any form of medication and wants to stop them needs to discuss that with their doctor. But interesting changes when it comes to antidepressants, and we'll go into the meat part of that in a moment or two. But as a general principle, medications are prescribed to treat a particular problem and should be continued for as long as that problem is there or would continue without the use of the medication. Equally, if side effects are a problem, then that medication may need to be ceased. Classic example, if somebody's allergic to penicillin, then they can't and should not take penicillin. If they break out in a rash, you've got to stop taking it, go back and see your doctor, and it's not going to be a medication to be prescribed again. Doesn't mean other people can't take penicillin. It doesn't make penicillin a bad medication, but nothing is suitable for everybody. The Australian drug regulator is going to require, and this is the Therapeutic Goods Administration, has followed the European Medicines Agency in recognising sexual dysfunction, which is a relatively common side effect of selective serotonin reuptake inhibitors, can persist in some people for a number of years. All SSRI and similar medications, and this includes a group called SNRIs, so selective serotonin, norepinephrine. Yeah, even doctors struggle with some of these words. It's why we have acronyms in medicine. Those reuptake inhibitors will all carry a warning that the drugs, and I quote in inverted commas, may cause symptoms of sexual dysfunction. And some of this can persist for years. There have been reports of long-lasting effects even after the medications have been stopped. In fact, there's another report, and this will be in the links below. You'll be able to find those. That as many as 1 in 6 people who've been on these medications may have some withdrawal symptoms. Now, they will also pass after a period of time. But what can happen, and this is very important because often both doctors and patients are not aware that symptoms may come on after a medication is stopped, and typically with antidepressants they need to be reduced quite slowly. But those symptoms may be very, very similar, in fact identical to the original reasons why people were started on the medication. And if we're not aware of that, then it won't enter the thinking and we'll just assume you need to keep taking the tablets. 1 in 6 is a reasonably significant number for a class of medications when they were launched, and this is in the late 80s, early 1990s. The first medication was fluoxetine. Its brand name is Prozac. Most people will have heard of that medication. There are quite a few now in that category. They're not the same. They're similar. They work in a similar way. That one of their selling points was that there weren't withdrawal symptoms, and it is very correct and important to say that they were certainly safer than the tricyclic antidepressants which preceded them and are still available. There's been a push worldwide by people who've suffered PSSD, post-SSRI sexual dysfunction. And a lot of these people, as often happens in medicine with patient groups, they really do struggle at times to be heard. And individuals in particular can struggle to be heard, and they tend to band together in groups. And I think I've mentioned on a previous podcast about risk.org, which is a website which was started by Dr David Healy, an Irish psychiatrist, and there are a lot of tales, maybe not the best term to use. There are a lot of stories from patients of their experience on that site, and I'd be pretty surprised if there aren't chat groups on Facebook or other social media sites where people with similar problems converse and seek to try and help each other. Now, it's also important to be aware that not everything in these chat groups is always going to be 100%, and whilst the internet has its uses, and certainly not all medical information on the internet is wrong, a lot of it's quite useful, not all of it is right either. So from the TGA, they're saying that these effects can persist for 12 months to 3.5 years. And I'll quote, persistent sexual dysfunction after treatment is stopped is thought to be rare. However, these symptoms are likely to be underreported and their prevalence is not currently known. Health professionals should be alert to this issue and consider if current or previous antidepressant use could be a factor in patients reporting sexual dysfunction, and report, and that's to them as a regulator, if they are suspicious of an association. So underreporting of side effects is a worldwide issue for a couple of reasons. Patients may not always report them to doctors. They might not always be recognised as such, and often doctors will overlook and not through bad intent, but overlook side effects and just see it as a new symptom that needs to be treated, and then we end up prescribing more pills to treat the side effects of pills, and sometimes unknowingly. And this is not a criticism of anybody. This is just the way the system operates. And even less are going to be reported to regulatory authorities because it's just a lot of paperwork that typically individuals don't want, and I get it. And I can certainly, and I can't speak for all doctors, but I'm yet to meet many doctors who like bureaucratic forms. It just takes a lot of time, and you typically aren't that sure as to what will actually come of it anyway. But so underreporting is an issue. Okay, what does this all mean? We need to pull it back to the very, very beginning. And in mild and moderate depression, there is no benefit to use of an SSRI medication over placebo. Now, when some of the original trials and data were put forward, it showed a significant benefit in published data. There was a lot of unpublished data, and you can find all this information online. So when the unpublished and published data was combined, the benefit disappeared. So it was 50-50, which is not to say that they didn't work, but they didn't work any better than placebo. And what that means is people got better, which they did, because they were taking a pill rather than because of what the pill or tablet was or medication was actually doing. And that placebo effect is a very real one. We know that. We see that in all trials. People are put on blood pressure medications in a trial, and some people are on the placebo, and some people in the placebo group, their blood pressure goes down. The power of the mind. And it is never more so than in mental health issues, which I really want to emphasise. Doesn't mean that there isn't a role for medications, and it doesn't mean that they don't work for people. But what it does mean, and what we do know, and the estimates are that 1 in 6 or 1 in 7 people, certainly in the United States, probably in the UK and in Australia, are on these medications. This is the SSRIs I'm talking about. There's probably a fair number who don't need to be on them. Does that mean they don't need treatment? No, it does not mean that. Are there other ways that depression can be managed? Yes, one can look to deal with what it might be that's making you feel depressed. Regular exercise is good for depression. Mediterranean diet has been shown to improve symptoms. Getting enough sleep is important. Sometimes just getting out in the fresh air can be beneficial. Meditation, guided relaxation, and of course, talking with people, and that can include friends sometimes if you're happy to do that, or family members, or of course, counsellors or psychologists, and there are online resources as well. So that people may need help with or treatment for a particular problem should not and is not, and until fairly recent times was not synonymous with, okay, you just need a tablet. Alrighty, so what's the bottom line in all of this? We need to be collectively, and this is regulators and the medical industry and individuals, because ultimately it's the individuals who are on the receiving end with all of this, aware that there is no such thing as the proverbial free lunch. All medications can have side effects, and that this group of medications, the SSRIs and the SNRIs, can create longer problems in terms of withdrawal symptoms and PSSD. Not saying everybody's going to get it. Absolutely, if you're on medications, don't stop them. Chat with your doctor about them. But if we're aware of these issues, then number one, we can at the start ask ourselves, well, is this what I want to do first up, or might there be another way that I can treat the issue? And number two, when it does come to wean off, be aware that some of the symptoms that may come back may be a function of withdrawal from the medication rather than the underlying issue returning. Thanks for listening to Dr. Joe Unplugged. If you enjoyed this podcast, please subscribe, like, and share. You can also follow it on all the socials. There'll be new content uploaded each week.